So welcome to another episode of DrDoctor Will See You Now, the podcast where we explore the intersection between technology and operational change in the NHS. And I'm really excited to say today we're going to be talking about a subject which is really close to my heart, which is giving patients choice, control and agency through partial or choice booking of appointments. Now, this is special to me because the very first thing I ever did when I worked in the NHS was help Coventry Hospital move from a full booking to a partial booking process many, many years ago. And so I'm absolutely delighted to have Mel, who's Deputy Director of Operations at Imperial Healthcare, NHS Trust. I hope I've got that right. And an expert in patient booking models to come and talk to us about the work they've done. Mel, would you like to introduce yourself?
Yeah, hi, thank you so much. I'm Milica. Everyone calls me Mel. That's how I'm known at Imperial. And I'm Deputy Divisional Director of Operations, work for one specific division. And I was responsible for rolling out the digital booking and changing our model of how do we book the patients from moving us way too far in advance into restricting to only 6 weeks in advance.
Amazing. And I can't wait to hear more about this because from what I hear, the results have been really fantastic and has been incredibly positive on the operational side. Can we start right at the beginning? So before the project started, what was the problem and why did you start the process?
Yeah, so I work for Imperial for a while now, just over 10 years. And I went through the ranks, did almost every single banding and job, moved around the different departments. And I was always fascinated about the bookings and how we can improve that, because that's the start of the patient pathway. It's the first contact that patients usually have with our hospital or any hospital. If you don't get that right, everything else falls down. RTT, patient experience, trust performance, income, it just snowballs. So I was always very interested at it. And then opportunity was presented to me to take outpatients department at Imperial, which I took actually. I really wanted to do it. So it's not they had to beg me. I probably begged my boss more and said, please, let me do it. I want to give it a go. I spoke to quite a lot of managers around the hospital and a lot of our clinicians to kind of just do a little bit of a deep dive. What is it that's frustrating them and what is it that doesn't work for operations? And then we work very closely with Helix, who did quite a lot of user insights for us, specifically on the side of the patients. What is it that they're frustrating them? The number of letters that we are sending, which is just,
Crazy amounts of paper.
Just crazy amount of paper in the 21st century was something that really bugs me, and I wanted to resolve it. And also the impact on the finances is significant. It's not cheap to send that many letters. And then I looked into some of our data. For example, we looked into the number of booked appointments and then the number of patients actually attending the appointment. And the contrast is quite significant. We booked around 1.7 million and attendance is around 1.2 million.
Right, okay. There's a huge amount of waste there.
Huge amount of waste. And if you just think from the operational perspective, rebooking all of those patients, that takes not just staff, but it's a huge amount of work. And the likelihood of getting it right reduces every time when you cancel the patient. Yeah. And then we finish in a problem where patients are not booked in chronological order. The RTT is not improving. Patients are frustrated. I don't even want to talk about that because that's just a poor experience. And I use example of the airports and airplanes. And I said, can you imagine if we are booking our planes tickets and then we book 1.7 million and then we just cancel 700,000? That would not be viable business in any shape or form.
It wouldn't exist, would it?
It wouldn't exist. So why it's okay to run the public organization like that? And I was adamant that we can improve it.
Yeah, and we see these sort of stats in every hospital we work in. So 30 to 40% of appointments booked never happen. Hospital-initiated cancellation, patient-initiated cancellation. And, if you think about that in terms of resource, it's probably 30 or 40 people full-time just managing that churn. And then the other really fascinating stat that the team have found is for every time you reschedule a patient, the DNA rate goes up by 2.5%. So as you say, we're creating work for ourselves and a worse patient experience.
And every time when you do that, you send a letter. So there is a booking letter,
Of course,
cancellation
yeah.
letter, rescheduling letter, rebooking letter, and then it just goes around. And majority of the times, all of those letters arrive at the same time. And we do that without even speaking to the patient once. So as a patient myself, we're all patients. We all have attended hospital in some shape or form. For me, it was just, okay, can I just get one letter? I just want to know when is my appointment, and I hope you won't cancel it. And I have started from myself and then worked through the problems with quite a lot of people. It wasn't just me. There was a full team of people at Imperial who was really on board on this journey and said, we need to try. We just need to try and give it a go. And it worked.
Yeah, you should always try and give it a go. And of course, you're really lucky at Imperial because you do have Helix and you do have all of that additional resource. And I presume that helped. But thinking about that problem statement, I assume this is the same for everyone. So if there was somebody listening to this who perhaps works in an organization that doesn't have that additional resource, how do they get started?
So we do have a quite ambitious outpatient transformation program. So yes, we are very, very lucky in that sense. But it is possible to be done just with operational management involved who wants to change. Now, the setup in each organization is a little bit different. And I believe in order for this to work, there has to be a centralized booking team. So that, first of all, you can implement change quicker. You can do the phase way and roll it out across organization in more structured, safe way. And also you can train your workforce to do exactly what needs to be done. So we were quite lucky that Imperial is majority centralized. Yeah. We're in the process of finishing that and getting all services on board. But I think that played a quite big part because as somebody who was responsible for outpatients, I was responsible for all booking. So when I got the pilot services on board and clinicians wanted to try something new because nobody could have argued that it works. So I didn't have to make a case for change in that sense. I just had to make the case that this is different and that I believe that it's going to work. Now I'm a very energetic person.
Yes.
And I have a big personality.
Yeah.
So I'm happy to use that and just get people motivated, get them on board and say, we need to try. Or we're just going to year on year complain that it doesn't work.
Exactly. I think you tell a great data story as well, because I think that's the other side of this is once you start looking at some of those numbers, you realize how endemic this problem is. And it's not a sensible way to run anything. And, we know that there's a direct correlation between DNA rate and how far away you book an appointment. We know that for a fact. Your point about clinicians is interesting because I certainly remember when I first started looking at patient self-booking and choice, one of the arguments that landed really well with my clinical colleagues was giving them some flexibility. Because obviously the challenge is at the moment, if you want to book leave, it means you have to do a whole load of rescheduling appointments. Were there any other conversations you had with clinicians early on in this sort of journey that either positive or negative?
Yeah, I mean, there was both, delivering change of this scale in an organization as big as Imperial is never straightforward. And not all of us are on the same page, but I believe in a journey and taking us through the pain and through the success. There was a couple of things. Our consultants, probably every consultant across the country, they like to see their clinics booked.
Yes.
Okay, they like to see them booked in advance. They like to know, and we cannot blame them for it. I like to come to work knowing what meetings I have in my diary. And then you can plan your day. So I have understood that. But I think when I have presented them the case why I want to try this and why I believe in it, it was difficult to argue that it's okay to cancel patients 3 times in average. I think that's it's difficult to argue for what reason. We should not be canceling. So we should not be booking patients into capacity that we don't have. That is not confirmed.
Right, totally.
If we do want to do that, then we have to change how we do it. There is no point of promising appointment that we know 40% of the chance it won't happen. And I think when we went into those conversations, there were consultants and services. They were like, okay, let's try. Let's give it a go. We had to develop quite a lot of other things, the dashboards to support them to see the lack of capacity that we have to understand the backlog. I wanted trust to understand the backlog, not just managers. I think it's all of our problem. It's not just one or a person's problem. And I think when we start going through that, then it became a little bit easier. Now we have quite a lot of consultants at Imperial, so everyone manages clinic in a different way. And the point that I have made is we can't manage organization like that. It has to be standardized or as close to it as possible so that we can then manage administration in a way to deliver. Productivity is quite a big thing.
Right.
In the last 2 years, more than ever. It's almost the only thing that we're talking about. It's the productivity. If you're canceling 700,000 appointments a year, just the pure administration that I need to run it properly so that we don't lose the patients are not missing their appointments. I think it's impossible. And I'm yet to see any organization who managed to do it properly.
Your point of standardization actually does create flexibility ultimately.
Correct.
And when everything's done differently, you cannot run a productive organization. And I love, and I would like to spend a bit more time on later, the backlog is everyone's problem. It's not the management's problem alone. It's, as an organization, how are we going to solve this problem? And that's exactly the right attitude. So Mel, can you just dive into a bit about how you design the 8642 model?
So the 10-year plan, NHS England, came out, and it was that every patient needs to be validated before it's booked.
Yeah.
Okay, and we all believe in that. Every manager does it.
Totally.
But the pure volume, validating 1.7 million appointments, it takes a bit of a time.
Yeah.
It's not as straightforward. Now with technology, it becomes a little bit easier.
Yeah.
So we have used DrDoctor technology, but there is also the different providers there. And we were like, okay, so we want to validate all the patients.
Yeah.
How we can do that? I can't put the workforce on it. I don't have it.
Yeah.
So, okay, let's start texting them. Do you still need this appointment? It's actually as straightforward as that. And then when should we do that? Okay, now you can go private, your circumstances changes, you move out, loads of things, loads of reasons why a patient's not attend. So we decided for that to be 8.
Yeah, okay.
Okay. Now we run 642 in theatres. It's a well-established methodology and it works very well. So for me it was like, well, if it works in theatre, why can't work in, why we need to have so many different methodologies? Why
Consistency again.
Correct. Much easier to train people, much easier for managers to understand it. Just easier, isn't it?
Yeah.
So I was like, okay, how we can do the 642 now in outpatient settings?
Yeah.
And then I was thinking about consultants' annual leave. Now in our organization, the policy is 6 weeks. I'm not so sure if that's everywhere.
I think that's quite consistent.
But I do think it's quite consistent. So, okay, and 6 weeks we will lock capacity.
Yeah.
We know what we have. We know what we don't have. Of course, there are always cancellations. Hospitals are big. We have a lot of pressure. But majority, we know that on the 6 weeks, we will have capacity locked in. And then we can start texting patients, book yourselves in. So we decided to restrict capacity to 6 weeks. 4 weeks is when let's mop it up.
Yeah.
What is not booked, short-term cancellations, additional clinics, loads of things can happen in operational world. So we have locked it on the 4.
Got you.
And then on the 2 is just, let's book the urgents that we have not done, cancer patients that we have not done. Let's populate those clinics. And that's how we came up with 8642.
That's nice.
Now it was too long.
But the 8?
Not catchy.
Yeah.
So our lovely communication team says, well, actually, Mel, what you're doing is providing the choice to the patients. And then that's how the choice booking was born. And that's how we have
choice booking.
Yeah.
So this is one of my bones of contention here, Mel. So talk to me, because this is partial booking to me. But you don't like partial booking. You like choice. Tell me, what have I been wrong about for the last 12 years?
I don't think you're wrong. I think the word is wrong. So partial booking means that how at least Imperial did it a long time ago. You book the patient partially, okay? And then somebody needs to call the patient and confirm the appointment.
Right, okay.
Okay,
Yeah.
I don't believe in that because you need to call 1.7 million patients. It's a lot of patients
we're not
to
do
call.
that,
There is no way you will be doing that. And I mean, you will try maybe for 6 months and then everything will collapse, which then means the DNAs will go up. The patients will start being lost in the system. They didn't get the letters. So then you rush with the letters and it just snowballs down, isn't it? But I do like the concept, but not the word.
Okay. So we're going to agree from now on, it's choice booking.
I believe it's a choice
We're
booking.
going to go with choice booking. We're going to put partial booking in room 101. We're going to put it in the bin.
It's not the bin. It's I would put it in my like a pass box. History.
Fair enough. Because to be honest, what I would historically have called partial booking is what you call choice booking.
Exactly. So it's the same principle. It's just I think lots of organizations had a bad experiences with it. It's not just Imperial went through a little bit of a problem. I think that we all experienced different, and it's because of that. It was just the way of how I believe if you book the patient, it's confirmed. It has to be confirmed. There can't be, oh, let's now maybe call them, play out, let's move them. It has to be, you lock it, patient is locked.
You get rid of all of that churn and all of those cancellations. Okay, so we've accepted that we're doing choice booking. That's great. So just tell me a little bit about how you manage your unbooked waiting list.
Capacity is a capacity. And I'm trying to separate those two together.
Yeah.
Okay, how you book the patient and the capacity you have, it's close together.
But they are independent, aren't they?
They are independent. Yeah. Okay. The patient gets referred to the hospital. The moment the referral is accepted, the patient is on the waiting list.
Yeah.
That's how we run it at Imperial. Now, those patients sit on those waiting lists. We don't contact them. There is radio silence until you receive the letter.
Yeah.
And then you receive the cancellation letter couple of times. Okay.
Great experience.
So yeah, it's fantastic. So what we have done is we start with with your products. We designed the welcome message. Okay. And we are texting them every 12 weeks to tell them that they are on our waiting list. We have not forgotten about them. Okay. We have a bit of a problem with news because it's a different system. We are on ERS there.
And ERS is a whole conversation that I feel that we need to come back to.
Yeah.
Both positive, but also really challenging for some of the operational change.
Yeah.
So I'd love to explore ERS, but I'm going to put a pin in that. Yeah. Keep telling me.
Yeah. But we still can text the patients.
Yeah.
So we have found a way around it by using the DrDoctor product, because you have your waiting list. If you have your waiting list, you can upload and you can text. You can always find a way to do it. It's not maybe the streamlined. There is always a way to do something. So that's why we implemented the 8 weeks text messages. Do you still need appointment? And welcome message. We know you're on our waiting list. Of course, it's our communication team who did the text messages, not me, because mine would be very simple, probably wrongly spelled.
To the point, and people would do what they said.
You know, I just believe straightforward.
Yeah,
okay?
Totally.
Without the fluff, but they're very, very lovely messages that my colleagues came up with. So we want to keep them engaged so that they understand that they are not lost. Because one of the biggest fear that our patients have, and the feedback that we got, is that they think they're always lost. And then that happens, but it doesn't happen as often, I think, as we think it happens. But it's one of those things that just becomes a fact.
And it holds people back from moving to choice booking, this fear of lost patients, doesn't
Correct. It? So what we did to solve that problem, I just presented, okay, those are the waiting lists. Yeah. They're not lost. They're there.
They're here, yeah.
We can see them. We're just not booking them. And there is multiple reasons why patients are not being booked properly. We have not one waiting list, but there is multiple waiting lists. But you only have one slot. So how do you decide which patient goes into that slot? So all of those are real problems that operational management has and that we need to resolve. And with this process, we have managed to improve it. We have not resolved it because for that we need a single waiting list. I think it's a must. Yeah. You need to have one follow-up waiting list. That's it. Yeah. Nothing else. There is no DNA waiting list. There is no cancellation waiting list. Everything
one source of truth.
Correct. So that you can then, because if you have a structured data, you can digitalize that data. You cannot digitalize something that you have a 5 different waiting lists, one slot.
Yeah, it's impossible.
How that goes.
And so often the rules around this are just in someone's head, right?
Yes.
And this is a big challenge, I think, with scaling anything in the NHS, is really talented people who are doing the booking, who know the rules, but they're not well documented. You can't digitalize it, and it's really hard to scale.
But also it's priority.
Yeah.
So how do you go about it? What is more important? And we are leaving those decisions to somebody who potentially should not be making those decisions.
Yeah,
And that's not fair on our staff.
Yeah.
Because,
and inconsistent again.
Correct. Then they need to come to work. This is the list. Crack on until we digitalize that. There shouldn't be, check this list now, check that list now, validate this list. It just creates this machine.
It's so interesting because we think about it a lot from the patient side, and that, feeling like you're in a bit of a black hole. I know from our stats that 40% of the phone calls to most booking centres are people chasing their referral, which just shows, and we know that when you send those messages to let people know what's going on, it reduces the stress, it gets rid of the phone calls. But I hadn't thought about the staff side. I hadn't thought about someone coming into work and being given this really stressful situation of those 5 or 6 lists, and they...
Correct. But also our priority changes all the time. Yeah. So one day the priority is, let's clean all 65-week breaches because that's the right thing to do, and we shouldn't have patients waiting 65 weeks, end of. But then what about the rest of them? Mm-hmm. And then, okay, let's go for 52s. No, now it's a cancer. And you're consistently moving your people and the administration. Now we're a big team. We're talking about, 50 people.
Yeah. You can't just move the goalposts all the time.
And people need to know what we need to do with as little changes on the day as possible. And I'm the first one who drives my team mad, because one day this will be priority, then I will be told something else is priority.
And you have to...
And it just raises this anxiety, the stress, and the work just becomes really unpleasant. While I find operational management probably one of the most exciting professions out there. And I want people to enjoy it because... we serve population.
You serve people, and it's a fun job, right?
It's such
because
a fun job.
You get stuff done, and you make a real difference to people on a daily basis.
And you can feel that. When patients are happy, it's, it puts a smile on all of our faces. At least it puts a smile. I still call our patients. So I would still, do if the DNAs went up or something, I would say, come on, give me 10. Let me have a chat to see why, what doesn't work. I think that's very important to keep that,
stay close to the problem,
with your people.
Yeah.
They are our patients, and we serve 1.4 million. It's a lot of people. 2.4 million, sorry.
Yeah.
So for me was I wanted to make administration a little bit more happier. I was a little bit tired of listening how administration it's not successful, it doesn't work, it's always booking problem, it's always, the booking team can do something better. Yeah, absolutely, we can, no question about it. But we also need tools. It will, you put both of my hands behind my back and ask me to do better. It's a little bit difficult.
I couldn't agree more. I feel like admin teams get beaten down on a lot by people, and I think it's really unfair.
Yeah.
I've spent my whole career working in hospital admin, outpatients, and the people that I meet care about that job so much. Yeah. They care so much about every single patient that...
They really, really do. And they're so important because without them, we would not have a hospital.
We would not.
Okay?
Yeah.
It's actually that simple.
Yeah.
And I think that they're getting quite a lot of bad press. But what I said to the team that I manage, and I said to everybody that I know, without you, our patients will not have any chance.
No, they would not.
They would have no chance to get around all of these processes, paperwork, governance that we have put in place.
What a reason to come to work, There's real meaning in that.
I think so.
Yeah, and this is like my sort of vision and dream, I guess, for DrDoctor is I want to be, every administrator's assistant. I want to be there helping them do their job, getting rid of the drudgery so that they can be helping people every day.
Exactly. That was my vision. My vision is let's automatize everything that we can in order for the workforce that we have is actually focused on the patients that need support. Not all of the patients need support. Exactly. It's maybe 20%.
Yeah, but then you can spend time with them.
Correct, and do it properly and support them. If you look into the DNAs, and we looked in our organization, we are very focused on we serve one of the most deprived population areas in London. So we're very focused on trying to reduce the DNAs in that specific cohort. And I want administration to do that.
Yeah, and we've certainly seen from sites that those less well-served populations, if you can spend the time with them, work with them on, find people that speak their native language from their community, the engagement levels are really high. And that's, this is what the NHS is amazing at, is when you're in the system, it cares so well for people.
Yeah.
And the job of, I think, the administration teams is to extend that out into the community as much as they possibly can.
Yes, absolutely. It's spending time a little bit with our communities.
It's caring.
Not, exactly. It's a caring. It's not just transaction. This is, there you go, letter. It's actually spending time, have a chat a little bit. Listen, we're noticing you're DNAing quite a lot of our appointments. Is there anything that we can do? Support.
Can we help?
Rescheduling transport, support, organizing the translation. There is quite a lot of work that we can do, but we can't do that if we need to reschedule 700,000 appointments a year.
Here, Mel. And I'm really excited by how technology can help with this as well, because things like the translation and language requirements, as we bring in more AI sort of automatically translating, I think is going to be really exciting.